All right, afternoon, everyone. Welcome back. Thank you for joining us for the next session. The topic of this session is going to be interventional approaches to AMI shock, and we got a fantastic group of panelists and speakers here for the session. We're going to have Saras kicking it off with a talk on state-of-the-art principles of AMI shock management.
All right. Thank you. Hi, everybody. My name is Saras. I'm an interventional and a critical care cardiologist at Brown in Rhode Island. Thanks for having me. Thanks to Michele and the organizers for putting the session together. So I'm trying to condense AMI shock management, just broad brushstrokes, into 7 minutes. So I will skip over a few things. Please excuse me. I'm trying to paint a bigger picture and stay away from the specifics. But happy to delve into that in our conversations. Many of us here are shock enthusiasts. We understand that shock is largely a perfusion problem that manifests from a primary cardiogenic issue, but can often have multiple other etiologies. So this is the classic paradigm where we break up shock into based on how the patients look between cold and wet, and if they are cold and warm and wet and dry. And so largely when you put patients into this 2x2 table, this is the classical cardiogenic shock where they're cold and wet, but often we see mixed phenotypes where they have some extent of vasodilatation, but pure vasodilatory shock is likely not cardiogenic in nature. It's likely more either septic or neurogenic or other etiologies. So I wanted to put this out there because instead of fixating on the hemodynamics, I think we really need to drill down and think about tissue-level perfusion as the manifestation of shock. Back in 2019 and then updated in 2022, the Sky Shock came up with a paradigm of classifying it in stages A through E, not dissimilar to the Intermax classification, not too dissimilar to the NYHA classification, but fundamentally to tell you that shock comes in various gradations of severity. And then it's not just the staging of shock, but also multiple phenotypes of shock, looking into modifiers that bring about a difference in outcomes. When you look at cardiogenic shock care broadly, in the cath lab, in the CICU, again, this is specific to AMI shock, there are multiple priorities. This is the large, big palette of how you treat shock, but then we're going to go into certain aspects of it. The biggest issue that continues to plague us in this field is recognition of shock. I think we still struggle with the idea of understanding shock. This is from the FIT-STEMI trial where you see there's a clear separation in delays in care for these patients. So door to balloon has a bigger, delays in door to balloon has a bigger penalty in those with shock, with or without concomitant cardiac arrest, as compared to those with only arrest or neither of the two. These are data from the shock working group where we looked at stages of shock and how they change over time. And as you can see, the largest movement is in the first 24 hours, where patients often morph into a different stage, and that stage at 24 hours, or the golden day of shock, determines their trajectory in the remainder of their hospitalization. Revascularization, for the longest time, has been the only thing in our armamentarium that has shown correlation with good outcomes. This is the shock trial now published almost 2.5 decades ago, where, again, the primary endpoint, 30-day mortality, was a neutral endpoint. But what they really showed improvement outcomes was at 6 months and in those younger than 75 years, specifically, so 6 months and in those who were revasked within 6 hours. So these are two important criteria. So not just do you have to treat them early, you have to treat them effectively, and revask was the only thing we had. Revask strategies have then been improved upon. These are data from the Culprit shock trial that tell us that we treat the culprit only, get them off the table, get them into the CICU, optimize them, and bring them back for non-culprit disease as they make clinical progress or if there's a hemodynamic deterioration. These are data from our group that looked at utilization of angiography, and as you can see, despite being a class 1 recommendation, only about 60 to 70%, maybe 80% in recent times, patients end up getting revascularization. Antithrombotic therapy, there are a lot of good data. This is our meta-analysis published a couple years ago, but what we looked at was ticagrelor and prasugrel, compared that to clopidogrel in those with AMI either complicated by shock or arrest. And we showed that in those with shock, it favored a lower mortality without any penalty of excessive bleeding. There are newer data coming out on P2Y12 inhibitors. There was the initial study, now almost 5-6 years old, that looked at TIMI flow grade after intravenous cangrelor that showed an improvement in TIMI flow rate maybe a signal towards mortality, but no real increase in bleeding. More recently, from the SCAR registry was published, this was published in JACC Interventions, where they looked at cangrelor and compared that to patients not getting cangrelor. Again, take this with a pinch of salt because it's retrospective, but in the shock cohort, there was a signal towards improvement in outcomes. There are multiple MCS selection algorithms. I'm not going to go into them. These are very specific to the given phenotype and the substrate in front of you. What I did want to show you that after the publication, there's going to be a talk on danger shock, but after the publication of the danger shock trial, there was an independent patient-level meta-analysis that looked at both unloading and loading MCS, because we know ECLS shock and ECMO CS were negative trials. So when you put these into context, unloading MCS, which is specifically the Impeller CP device, and especially in patients with STEMI without hypoxemic brain injury, so it's a very specific subset, is where the maximum signal of benefit was. So using a device indiscriminately in the wrong patient substrate is going to result in neutral or even poor outcomes. I'm going to skip over this slide for the sake of time, but just wanted to highlight to you the importance of alternate mechanisms of coming at shock. So when this patient goes to the CICU, again, assessment of the shock is crucial. This is where the field of critical care cardiology has come into its own, understanding both central macrovascular hemodynamics and peripheral perfusion, putting it all together and coupling that with what our interventions do and where they fall along the ventricular contractility axis and the preload and afterload axes. There are lots of studies on vasoactive medications. The Optima CC trial that showed that epinephrine was comparable to norepinephrine, but just at higher rates of refractory shock. The SOAP2 trial, which is old, which compared norepi to dopamine and showed that the shock patients did poorly with dopamine as compared to norepi. These are our data from the shock working group, but what I wanted to highlight to you here specifically was that patients, when you cumulatively calculate their vasoactive burden, it has a far more significant prognostic indication than any MCS or SCAI shock stage. So that is something that's not often thought about in shock patients. Complication management, this has been talked about in other talks, but briefly wanted to highlight to you about why complications are important. This is again from the shock working group where we looked at limb ischemia. Clearly depends on the MCS platform size, but also depends on patient substrate. There are multiple influences. Organ failure is important. While as cardiologists, we like to believe the heart is the center of all our work, which it is true, but multi-organ failure is a killer in the truest sense in shock. These are data from C3TN and from our group historically that have looked at stepwise increase in mortality with every additional organ system that has failed in patients with AMI cardiogenic shock. So I'll skip over the shock teams and shock protocols for now, but in conclusion, acute MI shock continues to have high mortality. Unfortunately, it continues to suffer from delayed recognition, lack of protocol care. Interventional and critical care cardiologists form the linchpin of care for these patients, and then it's a team sport. Thank you, and sorry for going over.
Thank you so much, Saras. We're going to head right into our next talk. Just a note for our speakers, while the talks are 5 minutes, we do have a buffer of 3 minutes of Q&A time after each one of these next few talks, so feel free to use that time additionally for your talk as well, because we also do have a large chunk of discussion section at the end, okay? So next I'll be presenting Dr. Nima Aghili, who will be speaking on danger trial impact on AMI shock.
Thank you so much for the invitation. I'm discussing the impact of danger trial, especially the impact that it has in our program, in our cardiogenic shock program. Oops. My disclosures. I'm going to start with a quick case. A 57-year-old guy, usual risk factors, came to our ER with two days of chest pain, this EKG, clear-cut anterior ST elevation. Took him immediately to the cath lab. He has an EDP of 30. His blood pressure is 92/78, low enough that nurses keep asking you, should we give neo? Should we start patient on fluid? His lactate is 3.2. He's in moderate respiratory distress, studying 90% on 4 liters. We all been there, dealt with these patients. It's a very morbid condition. Mortality still hovers around 50%. But is it really about the pipe or the pump? Fortunately, my interventional heart failure training make me kind of look beyond the being a plumber and think about all the other pathophysiology on the right, increasing filling pressures, cardiac ischemia, microvascular ischemia, central venous congestion, organ failures, kidney failure, liver failure, and so forth. And this is one of the reasons I love the danger shock trial, because I think this is actually an interventional heart failure trial trying to address the same concern. You all see the slide probably 100 times already. Inclusion criteria: patients with STEMI, hypotension as defined with SPP of less than 100, signs of hypoperfusion, including lactate more than 2.5, 360 patients randomized in 1-to-1 manner to standard care versus Impella CP device. You all have seen the result, significant outcome, significant toward the treatment arm, Impella CP, 12.7% reduction in all-cause mortality in 180 days with number need to treat of 8. To date, this is the only MCS trial that has had positive outcomes, comparing to obviously the IABP shock and ECLS shock trial for ECMO in ACS cardiogenic shock. I'm now going to try to address a few elements of a successful shock program when it relates to danger shock. One is the use of PAC catheter, Swan-Ganz or PA catheter. What's the usage in danger shock? As you can see, the numbers from the patients who made it to the ICU on the treatment arm, 74% got the PA catheter as opposed to 68% in patients who were on the control arm. How are we doing in the US? This is an observational study of 13,000 patients over 17 hospitals across the US. From 2017 to 2021, only 55% of these patients had the PA catheter in. And as you can see, and not surprisingly, the use of PA catheter is associated with less mortality, less risk of a stroke, and less risk for readmission. There is another concept that I like very much so, and I try to include that in our cardiogenic shock program. I call it the door to PAC time. This study shows, fairly recent, that as you can see on the graph on the right side of the screen, the patients who get the PAC, the PA catheter early on, which defined as less than 6 hours, they have better mortality comparing to patients who were delayed, which was defined as more than 48 hours. When it comes to mechanical support, patient selection matters. As you can see in danger trial, patients above the age of 77, there wasn't much benefit in putting these devices in. So in our program, we have a thoughtful pause when we have patients above the age of 75, especially if they're frail. Also, time, how much time passes since the onset of symptoms really matters. The longer the time is, the less the benefit of these devices will be. So a lot of patients that treated in the danger shock were Class C or Class D patients. When the time passes, especially past 16, 17 hours, when the patient gets to a stage E, there might not be that much benefit of starting these patients on MCS. The concept of pre-PCI MCS, I think there's going to be more talks on it, but has been floating around for the last 10 years. Study after study shows it really works. In danger shock, as you can see, 84.8% of the patient they receive on the treatment arm received the Impella before the PCI. Escalation really matters, a really hallmark of taking care of these Impella patients. They do have a very simple strategy. Keep the device running for 2 days, do not touch it. If at any point they become unstable, you escalate. At day 2, you start winning the device. If you can't win the device within 7 days, then it's time to escalate. I'll pass on this one. I do personally advocate for more rapid escalation based on hemodynamic. This is also depicted in this work by Dr. Basir. This is the same protocol we use in our program. When we do put these devices in, we keep the patient in the cath lab. We repeat the hemodynamics if the CPO remains less than 0.6, depending on the PAPI and other factors, and we decide to add Impella RP versus ECMO and so forth. Obviously, when you study patient ACS shock and you're putting in mechanical support, there's tons of complications. I'm going to touch on bleeding and renal failure. Bleeding was 26% in the Impella group. Important to note, source of bleed, 23% access site. This is something that we can work on as interventionalists with adopting best practices. And time of bleeding is also important. Only 2.7 happen in the cath lab. 50% of the bleed, more than 50% happen after these devices are weaned off. So it really does require the shock approach in every stage of the care from the cath lab to the ICU. And same as acute renal failure, common in these patients, more common in the Impella group. Risk factors, it's important to identify the risk factors, higher P level, longer support time. So I do actually advocate for de-escalation as soon as the patient is ready. Hemolysis and suction events also should be taken very seriously. Back to our patient, he received an Impella CP, did a simple PCI. He had the device in for 32 hours. He was discharged home on day 4. Conclusion, early and routine use of Impella in selected STEMI cardiogenic shock patient can reduce mortality. Focus should be on shortening door to MCS time. Routine and early PA catheter use should be a standard of care. Hemodynamics guided escalation and de-escalation improves outcome. A multidisciplinary shock team focused on best practices is key to reducing complication and improving survivals. Thank you.
Thanks so much, Nima. We're gonna skip the Q&A for that, and just for the interest of time, go to our next speaker. This is Dr. Emani, who will be presenting complex cases of VA-ECMO.
All right, thank you. Do a quick case here, and probably because either I failed to understand the assignment correctly or because the selection of what comes in, a little bit of a different type of case. Just goes there. So, back one. 59-year-old male, out of hospital cardiac arrest, walked into work, worked on a factory floor type setting, found down by coworkers. Bystander CPR was initiated. EMS is called. EMS shows up. He's in VF. Initial attempts at field ACLS without ROSC. Transported to his local ED. Eventually, after a couple of rounds of ACLS, achieves ROSC, but of course his thready pulses, low blood pressure, gets intubated, started on Levofed, and that's when we get the 911, please help me call. So at that point, as usual, it takes about an hour to 2 to get stabilized, put into a truck, and sent over to us. Arrives, and this is our initial bedside echo. You can see severely reduced ventricular function, sinus tachy with some nonspecific changes on his EKG. Can't really mention much of the RV here from the limited views that we had, and someone who had chest trauma and the edema from CPR, of course, and being intubated. But ultimately, he had a modest troponin elevation on that first check in the setting of some EKG changes and no known cardiac history. We elected to take him to the cath lab. No obstructive coronary disease noted. So he was returned at that point to the ICU for care, placed on a variety of drips, trying to get his oxygenation better, but ultimately starts to get worse. This was late in an afternoon on our initial arrival. Through the course of the night, would come in the morning, and the urine output has dropped off, creatinine is going up, a very familiar and unfortunate clinical picture. So at that time, the shock team actually gets the initial phone call, and we take the patient back to the cath lab, already on dobutamine at this point, to put a PA catheter in and then kind of make decisions on what our next steps are going to be. And you can see here hemodynamics at that point, elevated filling pressures with a low cardiac output, and any number of measures just says we're inadequate cardiac function through both either CPO, PAPI, and otherwise. And there are different algorithms out there, some of them alluded to earlier. If you kind of look and try to decipher what this is, in our discussion, we kind of talked a little bit about potential etiology as it may affect what we're going to do next, but also how we're going to recover this patient long term. We felt that although this was predominantly an LV failure, there was an RV component. The patient was also not oxygenating well, so we had a cardiopulmonary failure picture. And given the history, we were kind of banking a little bit on an acute fulminant myocarditis picture as what might be happening. So we thought this patient could be a candidate for more durable support options, be it an LVAD or a transplant if we didn't get full recovery, but obviously needs something more acutely. And so the decision was made to proceed with VA-ECMO at that time. So cannulated, this is all done kind of in the cath lab real time. Cannulated, we maintain flows at about 4.5 liters per minute and started to wean pressors thereafter. Started on steroids. We can debate whether that's the right answer or not for acute myocarditis, but patient who's basically dying, we put that on. And because of that progressive renal dysfunction, also needed some CRRT briefly. Just a couple of notes on the ECMO cannulation and management. We used a 26 and 17 French system, distal perfusion cannula placed, and then we set our flows at about 50 cc's per kilogram per minute, or there's that also related ECMO flow website that you can do to calculate goal flow, set our sweep for normal carbia, and maintain oxygenation, obviously avoiding north-south syndrome. We wean our vent to minimal support. Actually, we will move to extubate if we think it's reasonable for the patient to follow commands and stay still. We did use femoral cannulation here because we were hoping for short-term support. And maybe one of the more interesting topics that would be worth discussing in the Q&A portion is we elected not to vent the LV at this time. Turns out after about 72 plus hours of support, we started to see LV recovery and pulsatility over the VA-ECMO system. We started to wean. This is an image from the weaning study. You can see some better contractility. We decannulated the following day using an inotrope to come off of the mechanical support, and then we weaned the inotropes over the next week. The patient's renal recovery got him liberated from dialysis and ultimately was able to be discharged without any inotropic or renal replacement therapy needs. So kind of an example of a shock team, cath lab approach to rapid escalation of care and some thought process as to why we picked the devices we did, with at least here a good outcome.
Thank you. Thank you, Dr. Emani. In the interest of still staying on time, I think we're going to keep with the trend of skipping the Q&A and just leaving that for a broader presentation. So I'm going to introduce our next speaker, Dr. Colin Hirst, who will be presenting a couple of cases for us on multivessel versus culprit PCI on microaxial flow pump, as well as pre versus post-PCI support for AMI shock.
Thanks, everybody, for the invitation, especially Marat and Michele. Let's get started. The first talk that I'm going to be giving here is about AMI cardiogenic shock pre and post-PCI support. Those are my disclosures. So this is a lady that came to our cath lab, 69 years of age. She's Mandarin speaking. Her coronary disease history dates all the way back to about 2020 when she had her first myocardial infarction. And she was treated percutaneously. There's a stent in the OM as well as in the proximal LAD. She had pretty aggressive in-stent restenosis, and ultimately she went down the pathway of surgical revascularization. So she has a Lima to LAD and then a free Rima T graft off of the Lima to her OM system. And she came back about a year prior to this presentation to a different medical center, and they stented immediately proximal to the anastomosis of the Lima to the LAD. And so she's coming back in now with chest discomfort. And you can see from her early evaluation with her vital signs, that she's hypotensive, and that her electrocardiogram showing that there's diffuse ST depressions across the anterior precordium. This, just for reference, was her LV gram back in 2021. She's on a number of different cardiovascular medications, notably 3 different anti-anginals. And this is her clinical data, but what I've circled here is just sort of the time course. Over the course of the evening, she was persistently hypotensive. And I think that this sort of is helpful for folks, and I'm in a hospital-employed private practice model, and we do not regularly have an overnight presence with residents or fellows, and so sort of this unblinking eye as a concept of how we're treating cardiogenic shock, really I think is important for institutions, and this is the type of person that probably benefits from this. And earlier escalation. So you can sort of see that she's not only hypotensive, but also, there's ongoing myocardial necrosis in the setting of hypotissue perfusion. this is her coronary angiogram, so she's got a stump occlusion of the LAD, and then you can also sort of see opacification of the obtuse marginal branch. And you can see her right coronary artery is fine. We'll just move on here. Actually, sorry, I didn't pay enough attention here to the hemodynamics. But she's hypotensive, sort of lower filling pressures, and when I looked back at these, her LV-EDP was around 25, and her pulmonary capillary wedge pressure probably was erroneously evaluated at that time. So, really elevated left-sided filling pressures, underfilled right-sided filling pressures, and then also hypotensive. Now you're sort of getting an idea about when we take a look at her Lima to LAD, you can sort of see that there's a paucity of contrast filling right at that area where it was previously stented. And looking at another type of view, you can sort of see here that the Rima T-graft is okay. And then in comparison, her LV-gram, you're starting to get an understanding that it's globally hypokinetic, basically from the mid all the way to the apex, involving the anterolateral wall. So the clinical challenge that we were sort of discussing here, and again, consistent with the title of the talk, is, what do we do here for this young lady? Is it referral for redo CABG? Will we talk about ad hoc high-risk PCI? What about a hemodynamic evaluation? Maybe the cat's already left out of the bag because I already provided you with the right heart cath data, but I think that this is important here when we're proceeding on doing any type of intervention, where we're talking about phenotyping AMI cardiogenic shock. And additionally, I think that it's important to do that pre-PCI, as it provides you with invaluable information so that a priori, you're thinking about either temporary mechanical circulatory support versus, I think, bailout or post-PCI TMS escalation if that's required. And I think that the room would agree, and then there's also literature to support that patients that have an appropriate evaluation and then additionally upfront TMS probably do better than those patients when we're talking about a bailout strategy if things don't go the way that we intend them to go during the PCI. And then additionally, I think that angiography-guided versus intracoronary imaging is essential here when we're talking about PCI planning. And so making the case for upfront temporary mechanical circulatory support, I have two different slides about old thinking, and these were sort of a collection of best practices and previous documented in sort of the journal and literature and then also in conferences. But now the newer thinking from circulation back in 2022, and I think that the pearls involved in this consensus statement is the identification and definition of cardiogenic shock when you first meet it. We do now have a lexicon to describe cardiogenic shock, and that was in some of my colleagues' previous slides about the SCI staging. Second is that, do we have a team of teams in order to be sort of nimble enough in order to deploy and escalate care where needed? And I think that that's what we're seeing here in that center column. We've talked a little bit about making the case for upfront, but based on the guidelines, and I think that, with dangerous shock now, you're starting to see that patients with a complication of ACS, short-term MCS, may be appropriate in that setting to help facilitate revascularization, and it sort of has been given a class 2A recommendation here. So then what do we do here? So, I typically, before I deploy any type of large bore, I take a look at the iliofemorals, and so clean enough iliofemorals for us to deploy 14 French sheath here for our microaxial flow pump. And then this was the sort of what I sort of said, the brown scrubs moment. Is the case over before we even get started? Trying to wire the Lima and then additionally trying to advance a guideliner because I could not advance the IVUS catheter ends up with an iatrogenic dissection of the subclavian. And I chose not to, we can talk a little bit about the approach here, but I chose a femoral approach here. And the IVUS catheter was a little bit bulky. We used a Phillips system. The drive line for OCT was actually not long enough for us to get to our target area for an evaluation. So this is sort of in real time. So we have reestablishment of flow down sort of the left arm. So I think that we can just leave that for the time being. We did balloon angioplasty of this target, the vessel failure, and then we followed that up with restenting this area. And then this was our sort of final result here. And we were able then to use IVUS in order to take a look at the dissection that we caused and put in a self-expanding stent there, really right before the anastomosis or the takeoff of the Lima. So again, fixing a problem that we unfortunately caused at that point. So we actually left the temporary mechanical circulatory support device in for about 24 to 36 hours. It was then de-escalated in the lab, and she did well, discharged to home with follow-up. So really, what was the clinical problem? I'm thinking, high risk and STEMI, especially in complex anatomy, developing cardiogenic shock, and what do we do to resolve the problem? I think that we talked about the importance of coronary revascularization here. And then, what about sort of a different approach? Should we take a left radial approach in order to help with the facilitation of intracoronary imaging, either through IVUS or with OCT, because of the reduction in length, and then additionally, sort of how it gets into that takeoff of the Nima. And then I think that, talking a little bit about, sort of patient intracoronary device or metal adverse reactions, you can sort of see that a lot of her coronary disease, I think, was actually in-stent restenosis. And so there's sort of a coronary patient incompatibility with any type of metal. And a lot of the progression of her disease potentially was either because of stent placement that either maybe didn't undergo or placement at the time without intracoronary guidance. And I think that sort of ends up sort of giving us a really good idea about how best practices in treatment of some of these lesions may actually help with patient longevity in the future. So additional questions, Michele, we can end up sort of addressing questions now, or we can end up sort of going to the next talk, because I think that I have the next one as well.
Yeah, why don't you go into your next one, and we're going to save questions for the discussion at the end.
Okay, all right, okay. So that was our sort of discussion about pre versus post-PCI support, all right? Yes, perfect. Okay, this is great. So let's talk a little bit about, this is a case that we have that was some time ago, but nonetheless, I think that it helps to identify how best to treat patients that come in acutely, and whether or not you're talking about a pipe versus a pump problem, and then talking about complete revascularization. So 71-year-old gentleman, AMI cardiogenic shock, EF about 25%, and as well, moderate to severe low flow, low gradient aortic stenosis. You can see the echocardiographic indices there, V2 max for about 3.2 seconds, estimated aortic valve area about 1, and dimensionless index of 0.3. Q waves throughout the anterior precordial leads, and as well, there's chest radiograph looking there with bilateral opacifications consistent likely with pulmonary vascular congestion and pulmonary edema. Other medical history to be accounted for is history of lymphoma, and then also moderate to severe COPD. So when we're thinking about a coronary event as well as a valvular event, is this patient more of a surgical candidate, or should we end up addressing the acute presentation right now, and then thinking about alternatives for somebody that we may not think would be the best surgical candidate at the present time? Here's the baseline LV systolic function in a number of different windows, but you can sort of see here that the overall, it's globally myopathic, and that there's akinesis at the apex. And then the coronary angiography, some still frames here, but what you can appreciate, distal left main heading into the circumflex, large rock of calcium, and then additionally, that calcific burden also extends into the proximal LAD. Otherwise, really, there's minimal luminal irregularities or non-obstructive coronary disease in the remainder of his left-sided coronary tree, and he's got a non-dominant right. But here, I think, is really the important threshold, is sort of, again, phenotyping the cardiogenic shock when it walks into the door with a PA catheter. And you can see massively elevated intracardiac filling pressures here. That represents a biventricular failure phenotype. And not only that, he's also on norepinephrine as well as epinephrine. So the take-home message here is how best to optimize somebody like this prior to proceeding with any type of intervention. And so taking a look at his iliofemorals, we thought that really the right side would probably be unfavorable, left side more favorable for any type of large bore vascular access. And walking through this was sort of how we placed an Impella in somebody that we thought would be an appropriate candidate, but in the event that had a fixed obstruction across the aortic valve, that we would then have to negotiate. Step one, we really failed with just the 0.018 platinum plus guide wire. We tried a Safari buddy wire, but that also didn't help to facilitate. So we used a compliant balloon, a Z-Med 16 by 40, and helped to perform small balloon valvuloplasty to facilitate the placement of this type of device. And as you can see, really, the effect of that was profound. Again, addressing a hemodynamic issue that ends up having consequent and downstream hemometabolic derangements, were ultimately corrected. You can see the patient's time course of their creatinine as well as their AST and ALT. So really the hepatic and renal, the hepatosarca and the nephrosarca, due to the original derangement, has now been corrected, optimizing this patient's hemodynamic profile in preparation for our intervention. Here we did this with OCT. The proximal nature of this really could be done with OCT or with IVUS. You would be a little bit more concerned about using OCT if the left main was a little bit shorter because of contrast washout. But what I want you to all appreciate in the two pictures representing the LAD and the circumflex, from about 2 to about 5 is where you're starting to see hypoattenuation, really rapid hypoattenuation consistent with deep calcium. This was a mini crush revascularization technique. I'm not going to go through each of the different steps, but much less to say that this patient underwent Impella-supported bifurcation, dedicated bifurcation, stenting of distal left main, proximal LAD, and left circumflex. And ultimately, we were able to get a very nice result where this was the final result. And then that set him up down the road so that he ended up having a transcatheter aortic valve intervention. So really, I think that the take-home messages from this type of case is that pre-procedure hemodynamic assessment and optimization likely increases procedural success. Iliofemoral angiography prior to large bore arterial access likely reduces the adverse vascular event rate. In spite of significant aortic stenosis, there is a pathway to place these devices safely. And thinking outside the box to correct that type of problem helps with just imagining how that could potentially be done. Intracoronary imaging, I think, is paramount here with procedural success, and then also with the appropriate hemodynamic support platform and planned revascularization strategy. I think that the high-risk PCI approach here is predictable. So I'll stop here and then hand it over to my colleagues. Thanks, everybody.
Thanks so much, Colin. We're going to move to our final speaker of the session and then open it up to group discussion. This is Dr. Elie Kozaily, who's going to be presenting a case on E-CPR.
Excellent. Hello, everyone. Very happy and grateful to be here. Thank you, Dr. Esposito, for giving me this opportunity. So I'll be presenting a case of extracorporeal cardiopulmonary resuscitation, or ECMO, or E-CPR. So this is a 74-year-old lady with inferior infralateral STEMIs. You can see 2, 3 AVF, V5, and V6 ST elevations who presented to our emergency room. So she doesn't have any major cardiovascular history besides an incidental pericardial effusion that was noted on a CT chest that was being done for some dysphagia workup. She had some coronary calcium on her CT chest, and she was recommended statins, but preferred to stay off statins given her frequent flares of fibromyalgia. So this was a pretty dramatic presentation for this patient who was walking outside with her family when she collapsed. She was brought to the ED. She was pretty obtunded and hypotensive. She apparently never lost pulse before coming to our emergency room. So in the ED, she was given IV fluids. Her blood pressure remained 80s over 60s, so she was started on peripheral norepinephrine. And as she was being rolled into the cath lab, she went into PEA arrest and underwent chest compressions, then degenerated to VFib, shocked, PEA again, and when she showed up to the cath lab, there was ongoing chest compressions. So the first dilemma here is what to do next. Do we fix quickly as possible? Do we put a balloon pump? Do we put an Impella CP? Or if you want me to keep going, you'll choose D. Oh, sorry. All right, so the patient was intubated and then was crashed onto VA-ECMO. Left femoral artery, 17 French cannula was inserted. A right femoral artery was attempted initially, but had some retrograde dissections, so it was left alone. And then a right femoral vein, 24 French cannula was inserted, and the peripheral VA ECMO was initiated within 10 minutes of CPR, and the flow was 3 liters per minute, and the circuit was up and running. And so a right radial artery was used for coronary angiography. These are just still pictures, not in cine. But the left system had mild, non-obstructive, say mild, but diffuse non-obstructive coronary disease. And the right coronary artery had a severe, complete mid-RCA occlusion. And the patient had an LVDP of 20. So with a 2.0 compliant balloon, flow was restored, and then 2 drug-eluting stents were deployed. and we had good angiographic result, and the patient was transferred to the cardiovascular ICU and was being co-managed by a heart failure cardiologist and critical care anesthesia teams. And you can see that within 4 to 5 hours on VA-ECMO, the patient was developing worsening hypoxia, low ECMO flows, and the chest x-ray showed pretty significant pulmonary edema. Her SWAN numbers showed pretty severe RV dysfunction, RA of 10, PA pressure 17, 13, and a mean of 15 with a wedge of 17. Her pulmonary artery pulsatility index was 0.4, which is severely reduced. And I don't know if the echo picture will play, but her LV function was pretty robust, knowing that she was on quite a bit of vasopressor. She was on 20 microgram per kilogram per minute of norepinephrine, as well as 0.08 of epinephrine. So the decision was pretty difficult at this point. So what do we do next? Do we continue the patient on VA-ECMO? Do we add an LV vent? Do we provide support to the RV with an Impella RP or with a Protect Duo? And the decision was made to proceed with Protect Duo. And the reasoning behind that was that the patient had single arterial access on the left side. She had evidence of worsening RV function, pulmonary edema, and so we decided to go with a Protect Duo via the right IJ, providing support for the RV and with a VV-ECMO configuration. The arterial cannula in her starting to struggle left lower extremity was removed, and the PA catheter was placed via the left subclavian vein. Unfortunately, the patient was worsening in the ICU, worsening liver function, worsening kidney function, and by that time, her echo is showing severe MR, likely from papillary muscle ischemic injury. Her lactate was worse, her pH was getting worse, and the family decided to withdraw care that evening. So key learnings from the operator and the team. So patient selection for E-CPR, 70 to 75 is always a tricky age range. The second point is with low flows and narrow PA pulse pressure or failure of improvement of PA pulse pressure, think of RV failure, and multidisciplinary team and communication between team members, but also very important with family members to set expectations is always very important. Thank you.
Thank you so much to all of our speakers, which we've asked to stay on for the panel. Just a quick note, y'all. We're going to finish up with the discussion here and then take a break, but I think the agenda says that we have a discussion until 3:30, and it's like 2:45. We're not going to have a 45-minute discussion. But we cannot disrupt the timing and the flow of the final session. So the final session will start at 4. We will just do an extended break, but we'll keep on time for discussion on par to the timing of the others, okay? Like I said, thank you to all of our speakers. I do have, here's my overarching question, and it's sort of, I'm going to cheat a little and kind of tap into, our first session here when we spoke about some of these smaller MCS devices. But, the 2A indication as a result of danger and other data showing STEMI and Impella for shock, improving outcomes is huge. And obviously, this is going to have a trickle-down effect. And, the question is, how deeply is this going to penetrate the rural communities? And I wonder, with all this competition from these smaller size pumps, can these providers handle this? Is shock ever going to grow at these smaller hospitals, especially as more data comes out and guidelines is saying this is good for patients? Or is it an unreasonable expectation to expect these interventionalists to fulfill, to learn all these new techniques and implants and all these pumps?
Michele, excellent question. And I think that there's 2 points that I think that I'll make for the question. I think that what we're going to begin to see is you're going to start to see development of networks similar to how PCI programs were rolled out in the AMI networking when labs were first coming online, and then also developing a central system as well as the hub and spoke model in communities. And with integrated healthcare models, you're going to start to see that smaller hospitals that are integrated with larger systems are going to develop these networks. And there's data to show that these types of algorithmized approaches to patients, if they are reaching some of these spoke hospitals, or I guess sort of community enrichment centers, and then being sent to the central institution for escalation of care or further determination of what their advanced heart therapies could be, I think that that's really going to be the model. So it's going to be sort of more of a second coming of what we had seen in the 90s and early 2000s of development of these large networks in response to many labs popping up with the advent of percutaneous coronary intervention. I think that's sort of where I see how these rural hospitals will continue to help with this public health crisis.
Yeah, I might echo a little bit, and you ask the technical aspect. I think people will be able to learn. I mean, I trust all my colleagues out here, and we're all getting better at techniques, and the more we do it, the better we get. The calls that we often get, at least from the hub model, aren't like, I have the patient, they came in sick, I did X, Y, Z, they're on a support, and I'm stuck in the cath lab because the system doesn't allow me to transfer them to an ICU in this hospital. I don't even have respiratory support to help with the ventilatory. So, if it's going to become realistic, even with that transfer, it's the hospitals, the healthcare systems recognizing that it's not the interventional team or the cardiologist on call at 2 a.m. that has to do this all on his or herself, but you actually have to have a system in place, even if there's a triage and a holding time of 4, 6, 8 hours to get to the next place. And that's also, I think, where things fall apart, because they did fine, and then somebody didn't even bother to titrate a drip or check a calcium or replete electrolytes, and then they code in the helicopter on the way down because, unfortunately, they weren't equipped to handle it in another place.
I practice in Colorado, Denver, and we getting a lot of referrals from the rural hospitals. And to answer your questions about, how much have you done and how many have you done, I'll tell you, a lot of the docs that practice in these remote areas, they're not comfortable putting a 14 French. They come up with, and I understand, if you do 1 or 2 a year, or you really get comfortable in putting someone on Impella CP 14 French at 2 a.m., probably not. So they, somehow would come up with excuses to, putting balloon pump and send the patient over, and transfer can take up to 4 hours, and obviously patients coming in with a different condition. So I'm hoping, and hopefully soon, there's going to be a small bore devices available that would hopefully clear that resistance.
Yeah, I think all my colleagues up here spoke phenomenal points. The only thing I'd like to add is that the biggest challenge with executing danger is finding the right patient with the selection criteria. I think the selection criteria are very specific. And as you know, only about, I think data from the C3TN shows about 5% of all shock and 30% of all STEMIs meet that inclusion criteria. So it's not for all. A. And B, I think the place where danger really took a hit was the amount of complications, 26% complication rate. And I suspect it's even higher in clinical practice just from the variability in practice and comfort. So I would argue that not every site should have access to large bore technology. I think it should have a tiered system and that in parallel has appropriate CICU levels of care, appropriate heart valve transplant, and an exit strategy assessment, be it to recovery or to VAD transplant. So I think we need to have a thoughtful approach. I think we need to move away from the fact that AMI shock is a coronary problem. It's a ventricular problem where the coronary is also involved, and we need to think about it holistically rather than fixating on the oculostenotic reflex of an interventionist.
One additional point too, I think that it's important to probably sort of not only take an idea about what type of support devices you're going to be offering to the patient, and as Saras has mentioned, about really the crucial evaluation of these patients and looking at device patient compatibility. But really, from all of the operators and myself included, I'm the director of the cardiogenic shock program and the ECMO program at my hospital, and we've had to do a deeper dive as to understanding really what are the critical resources and taking in a true honest inventory of what we're able to do well and what we're able not to do well, and when it's time to ask for help. We do not have advanced therapies, for instance, VAD or transplant at our center, but understanding what it is that we're able to do and the threshold of support that we're able to offer before we're then going to have to ask for, we've reached our critical mass. And so I think that this goes out to everybody sort of here in the room as well as sort of, looking at these types of programs, you're really going to have to take an honest deep dive into what the institution you work at is capable of offering and what are the limitations.
Elie just presented a case of E-CPR, and I dealt with a case where I was plus minus a go or no go decision on doing E-CPR. And it's different when you're talking about E-CPR when you're standing there at the table and you're in the cath lab already and they start coding maybe during your procedure. That's very different because you're there to take care of and reverse it. You've got a whole team, you've got all the equipment, everything's ready to go. But if it's an E-CPR that doesn't happen in the cath lab, that becomes infinitely more tricky. And I wanted to know from the folks on the stage, do you have E-CPR programs in your hospital, and how have the outcomes been with that, if you do?
I can speak with my former institution. We started a very robust E-CPR program, educated EMS, refractory VT, VF in the field that activate, and we would meet, the ambulance would bypass the ER, we'd meet them in the cath lab. So we thought we had this all set up, we were great. It also happened to be 18 months prior to COVID changing a lot of things. And my tongue in cheek is if you're not Minneapolis and you're not Paris, France, it doesn't seem to work the way the literature shows. Very few of those patients were coming in with acute coronary issues and a fixable. This is in Ohio, and unfortunately we still deal with a lot of drug overdose. And VTVF is sort of a common end rhythm, dying rhythm, but I can't fix the anoxic brain injury. We're not sure how long they were down, the quality of the bystander CPR, and our outcomes were dismal. And just before I left that institution, we shut the program down.
I'm at Brown. We don't have an E-CPR program. We are very reluctant to start one for the reasons that Ramesh mentioned. I think arrest, unlike shock, the time is very limited. It's seconds to minutes rather than hours, minutes to hours in shock. And so I think we really need to perfect multidisciplinary teams internally in the hospital for states such as shock, PE, acute aortic syndromes, et cetera, which have slightly more flex room for time. And I think a large part of arrest care is pre-hospital. It has nothing to do with the physicians in the hospital. It's everything to do with the community, the bystanders, CPR, the EMS services that are available. And in all fairness, I spent a lot of time at Minneapolis learning their model, and the amount of buy-in they have from the fire and EMS services is tremendous. It took a lot of upfront investment, a lot of work. So I think it's very aspirational, but I don't think any of us can get there without that crucial piece.
And we also do not support a E-CPR program in our hospital. But if anybody doesn't know the reference that Ramesh was making, Google ECMO at the Louvre, and you will see an example of a mobile ECMO unit that has worked, I guess, quite well in Paris. Were you gonna...
For our program in New York, there's multiple different private practice cardiology groups, a hospital employed cardiology group, and then there's one cardiothoracic surgery program. But I think that, to echo some of the points that have been made already, and as well as to follow up on my previous comment, institutionally, we took a large and deep dive into what types of resources that we would need. We do not have 24-hour on-site perfusion, but we do not have 24-hour on-site intensive care, cardiothoracic surgery, intensive care, and then additionally the buy-in from the emergency medical services. Really, that is an operational Herculean effort that needs to be spearheaded and constantly reiterated, just because of so many different moving parts in the community about how patients are referred to different facilities. And so that's one of the reasons why we don't have an E-CPR program. But I think that's sort of one of the feedback that we have, was just being honest about what type of program that we want it to be. And, the outcomes do matter. And having an E-CPR program without the appropriate support probably is going to lead to poor patient outcomes.
We share the same limitations. The ECMO program is mostly run by surgeons and perfusionists. So if you are 35-year-old and you come in daytime, we can offer you E-CPR. But if you're coming, these cases, majority of them, as everyone knows, they come late, so there's no E-CPR option.
I just wanted to add one additional point. I think there's a paradox in arrest. Your best bang for the buck in arrest is younger out-of-hospital arrest patients that have VF or VT as they're presenting rhythm and often have coronary disease that can be fixed. And if they have good neurological outcomes, they would largely leave. But those are the toughest to get to. On the contrary, in-hospital arrest patients are easier to get to. They're often, multidisciplinary care team, ad hoc, which we have done too. We've cannulated ad hoc at the bedside. But the challenge is their arrest is often asystolic or PE arrest, and a culmination of all their comorbidities resulting in them having primary respiratory failure or metabolic failure, something else, which are often not as well recoverable. So I think there's a difference in ECMO outcomes based on who you cannulate.
This will be, and if the folks in the audience have any questions, feel free to shout it out. But this will be my last question to the panel before we wrap it up. And it's because it's a question that I got asked quite a lot. I wanted to hear what y'all's thoughts were. And the question was, after Danger Shock came out, everyone got really excited and wanted to know what indication it would get in the guidelines, and it obviously got a 2A indication, which I thought was great and was very impressive. And then the question that I got asked all the time was, will it ever achieve a class 1? Will any pump, microaxial flow pump or not, ever achieve a class 1 indication for STEMI?
I don't think so. I think that the heterogeneity of shock and the patient selection within the randomized clinical trial is selecting out a specific population where we thought that there was going to be a benefit to that population with the exposure of that therapy, but the heterogeneity of shock. And if you are going to then broaden the classification to a class 1, meaning that all comers are going to get this, you're really philosophically saying that there is some homogeneity in terms of therapy delivered for such a heterogeneous population. And I think that class 2A recommendation probably is the appropriate one.
I do think that it will get there. I think it's going to take some time. I think in 10 years from now, you might have a class 1 indication. As the devices get smaller, probably going to be more studies. Obviously, you need more validation. But I think and I hope we get a class 1 indication.
Yeah, no, I tend to agree more with Colin. I don't think it ever will get there, but I also think it's like asking if norepinephrine will be a class 1 recommendation. I mean, we should not be anchoring to a specific therapy. I think it's where that therapy fits into the overall schema of caring for that patient that matters. So I think if you had to make something class 1 in shock, I think shock protocols or shock teams should be way more important than something like a device, because you need to know when to use the device, what to deal with, how to deal with the complications of that device, and then what to do with if that device is not working. And that I don't think can be captured in a guideline recommendation.
Here's a heart failure perspective. Does a class 2A indication ever stop you from doing something in the cath lab? It doesn't seem like intervention need much evidence to go, and do things.
And if you see class 3 for IBP, it's still the most commonly used MCS device in every cath lab in this country.
I mean, do you guys even look at that? I mean, no, seriously. I mean, does 2A or 1 gonna make your colleagues think differently about deploying when they feel the need is there?
No, you're right in the sense that I would actually hope, my bias, that we don't see a class 1 indication, because all it does is hold us to metrics that we're going to look at some point and then say, I'm a good cath lab, I'm not a good cath lab, and then reimbursement's going to get tied more and more to that, and we're going to be answering questions that are not clinically appropriate for the patient in front of you. So I think 2A was a very fair recommendation based on the data. And will it get more uptake with or without that also depends on other things. In the absence of shock, door to unload, what's that going to end up showing? Supersaturated oxygen, or we're trying to reduce infarct size, we're trying to improve ventricular function. So I think there'll be other competing thoughts that say we should be considering and using these other, or using this a different set of tools. But I think 2A is fair, and my bias and hope is it's not one, because then even if I have a good outcome, someone's going to tell me I didn't do the right thing.
Yeah, I think that I'll agree with the majority of you. I don't think it'll ever achieve a Class 1, but for very obvious reasons. I mean, look at the guidelines. Look at all of the Class 1 indications. Do any of them kill you? No. They're largely very safe, right? But putting in an Impella alone, I mean, like if I was blindfolded and put an Impella in you, I could kill you. I mean, it is deadly to put the pump in alone in and of itself. So I don't think that there will ever be a Class 1 indication for a device that in and of itself has such a high risk profile. I think if these device companies would ever, and I'm not saying that a device necessarily can't get to a Class 1, but I think that the risk profile has to be mitigated so much more than what the current state is right now.
Can I ask a different question? If the danger shock was a negative trial, do you think the Impella in a setting of a STEMI shock would be a Class 3 now?
I don't think it would be a Class 3. But do I think it would have gotten a 2A? No. I think it's still like a pick and choose based off of the the patient's risk profile, kind of what their anatomy is, and kind of what you're looking at on the table. Wonderful, awesome. Well, thank you so much to all of our speakers and our panelists. Fantastic discussion. And